Hi, I'm Dr. Haleem. I'm with ReclaimAbility Pain Services, and today we're going to talk about different approaches to target the pain so we can get you back to your life as soon as we can. Sometimes we have patients come in who talk about injections that they've had in the past that were not as effective. And with technology and the approaches that we have for injections, things have changed drastically. Previously, epidural injections were the mainstay. Everyone was getting an epidural injection. If you got better, things were okay, and then we moved on. Now we can actually go after different types of pain. So for example, if we're doing an epidural injection, we're targeting the nerve pain, the pain that radiates down your arms or your legs. But if you look at the spine itself, the bony cage that protects the spine can also have problems. The discs can have problems. So we have different approaches, different techniques that target each type of pain. And the brain is annoying in a way where it focuses on the worst pain. So we can go after your worst pain, and then the next time we see you, the second worst pain is now your biggest problem, which is okay. We'll go after that second worst pain and try to keep you more comfortable. So a lot of times the bony cage that protects your spine starts having pain and you have more advanced arthritis. In younger patients, trauma or even having a car accident with a whiplash can accelerate the speed of arthritis. So in the back of the spine, you have tiny little joints where we can actually target those joints and block off the nerves going to those specific areas. So when you lean back and you have that throbbing, aching pain in the low back, we can try to help improve that so you're more active and it doesn't stop you from doing things you like to do. Spinal stenosis is when you have compression of the nerve roots. The spinal cord itself ends somewhere around L2, and below that you have the thecal sac. So larger joints, the facet injections help. However, when those joints become even larger, they start compressing on the nerve that's exiting at that level. On top of that, you've got a thick ligament, the ligamentum flavum, which causes some hypertrophy and causes compression of the spine at that level. So we can actually go in and shave off that ligamentum flavum and free up those nerves without having to do a laminectomy or laminotomy, or even a cage fusion. These approaches help with faster recovery and more improved function without having the downtime associated with surgery or the complications associated with surgery. Sometimes we have patients who've already had spine surgery, and in that case, you are essentially fusing certain levels of the spine. Each one of these levels are made to move. And sometimes when you fuse the spine, the levels above and below start having a lot more pressure, which causes adjacent disc disease and advanced arthritis in those levels, which becomes more of a problem when you are lower, somewhere around like L5, S1. And at that point, the next lowest level is the sacroiliac joint. So you have that deep, achy pain right at that lower pelvic level. And we can target the joints going to the sacroiliac joint. You can fuse the sacroiliac joint if you absolutely need to. Otherwise, reducing the inflammation and following up with aquatherapy to kind of strengthen up the pelvic girdle and take the pressure off the joint may prevent the need for further surgery in the spine. Sometimes you can have discogenic pain, which pushes out the disc down to the exiting nerve root, or even the spinal canal itself. In a younger patient, the recovery is a lot faster because you can put a little bit of steroid and that reduces inflammation and the body tends to heal itself. However, you may get some relief after a first injection, and then you may need a second just to improve on whatever benefit you have. Think about it this way. With every injection, we can target a certain specific area and we can put a certain amount of steroid in you in a day. So just because one injection did not work does not mean that the injections will never work again. Or even if an injection worked 2 years ago and then became less and less effective, it doesn't mean that it won't work now. So I think it's always worth giving a chance to an interventional approach rather than a full surgery. And obviously, when we start seeing patients not progressing, we'll recommend surgery ourselves, because it's more about getting you back to your life as soon as you can. Standard of care has changed a little bit when it comes to steroid. Usually we use dexamethasone, and that is a clear solution and doesn't cause the issues associated with particulate steroids, for example. Clear solutions don't clog up blood vessels and therefore reduce the risk of a stroke or another major complication in the spine. When we talk about spine injections, it's always scary to talk about someone putting a needle in or close to someone's spine. And a different way to look at it is, back in the day, people used to use no guidance. We used to palpate and then put a needle in. Now we use X-ray or fluoroscopy guidance where we know exactly where the bone is, and we're putting a little bit of contrast just to make sure wherever the medication is going is exactly where we want it to go. So we're confirming it at multiple different levels and multiple different angles before we even inject anything. That does improve the safety and efficacy of these injections.